Achalasia is the topic for this video, and achalasia is essentially a motility disorder of the esophagus. And the best way to explain this is with a photo. So here on the left side you have a normal esophagus, and this is of course the pathway through which food from your mouth will go eventually to the stomach. At the end of the esophagus is a very important muscle called the lower esophageal sphincter, and it is abbreviated LES. This sphincter relaxes and allows food to pass from the esophagus to the stomach. Now you have a photo showing achalasia. What happens in achalasia is that sphincter does not relax, and that way food cannot pass from the esophagus to the stomach, and as a result food or liquids build up in the esophagus, and as a result the esophagus will dilate. Some of the key features of achalasia is that you have impaired esophageal peristalsis. Peristalsis is essentially muscle contractions that move the food along. And as I showed in the diagram, you also have lack of relaxation of that very important lower esophageal sphincter. So why does this happen? Basically, the esophageal muscle has lost its nerve innervation. And this occurs because there is a loss of ganglion cells. And this lack of innervation is what's causing this problem with impaired peristalsis. In addition, because that lower esophageal sphincter cannot relax, you will have increased pressure. And this, of course, will cause, as the diagram showed, obstruction and dilation of that esophagus. So now let's talk a little bit about the symptoms. Patient will have difficulty swallowing, which is called dysphagia. At night, the patient will regurgitate food that he or she ate previously because the food cannot pass into the stomach. This can also lead to cough, and in worst case scenarios, pulmonary aspiration. And because the patient is having such problems with digesting food, eventually this can lead to weight loss. In terms of diagnosis, there's a test called an esophageal manometry, and I have a photo. So there's a little catheter that they insert down the patient's esophagus, and this measures several things that are very telltale. The first thing that this test does is it assesses the peristalsis. Second thing that it does is assess the function of the lower esophageal sphincter. So if someone has achalasia, what will be the results? You will see 100% failed peristalsis. Next thing you will see on this esophageal manometry is that the lower esophageal sphincter has incomplete relaxation, and as a result there is increased pressure. The second test that you can do, if you need to, is something called a barium swallow. And I have a photo of that. So a patient swallows some barium and you take an x-ray. Now this is the patient's esophagus. Now what do you see here? That arrow is pointing to the end of the esophagus where the lower esophageal sphincter is. Because that LES cannot relax, it cannot open, it remains closed, and that causes the esophagus to dilate over time. So this is a very characteristic shape, and this shape is given a name. It's called bird's beak, because if you turn it around, it kind of looks like the beak of a bird. And finally, treatment. Unfortunately, the peristalsis is gone, and there's nothing that you can do to help that problem. So the only thing that you can do is try to open that LES, try to decrease the pressure at the lower esophageal sphincter. And there's two ways. The first is something called a surgical, and that essentially just means that you cut the muscle of the LES. And here's a photo. So here they've done a cut, and what that does is it allows the lower esophageal sphincter to relax a bit, and that helps open up that area, which will allow food to then pass through. The next option is called a balloon dilation of the lower esophageal sphincter. And here's a photo of that. So here, as you can see, this lower esophageal sphincter is not able to relax. It's tightly closed. So you stick this balloon down, and then once the balloon is right in the middle, you inflate the balloon, and that opens it up. And then, of course, you take the balloon out. And the hope is that it will create an opening. It will create a relaxation that can be sustained over time, which will allow food to then pass from the esophagus into the stomach. So now let's take a look at a few vignettes. A 40-year-old man complains of increased difficulty in swallowing over the past 3 years. He reports a feeling of pressure in his chest occurring 2 to 3 seconds after swallowing a solid bolus. He also experiences regurgitation of undigested food eaten hours previously. A radiograph taken after swallowing barium shows a distended esophageal body and a smooth tapering at the lower esophageal sphincter. Manometry shows the absence of esophageal peristalsis with swallowing and a lower esophageal sphincter that fails to relax. What is the most likely diagnosis? They've encompassed every possible thing that a patient with achalasia can present with. A 50-year-old female with chronic dysphagia undergoes an upper endoscopy that reveals massive dilation of the distal esophagus. The esophagus is kinked and tortuous and partially filled with undigested foods. What is the most likely diagnosis? This question is not giving us as much information, but this is another case of achalasia. 43-year-old man reports that he has a 9-pound weight loss over the past 9 months. The symptoms have been accompanied by difficulty swallowing both solids and liquids during that time. He has woken on several occasions at approximately 4 a.m. and regurgitated partially digested dinner contents. An upper GI series is performed and reveals a widely dilated esophagus and a smoothly tapering distal esophagus. There appears to be partially digested food present in the esophagus. Which of the following would most likely be seen on esophageal manometry? Well, if you remember the results of the manometry, you would see two main things. The first is you would see failed peristalsis, and the second is you would see increased pressure of the lower esophageal sphincter. And of the answer choices, the best one that matches is choice A. And finally, a 34-year-old bus driver presents with complaints of difficulty swallowing. Symptoms began gradually approximately 9 months ago and have prevented him from chewing solids or drinking liquids comfortably. He finds himself awakened at night with cough and occasional morning regurgitation of recognizable food from the night before. He has learned to reduce his oral intake and has lost 6 pounds over the past 2 months. He does not smoke or drink and has no family history of esophageal or GI illness. His physical exam is unremarkable. Which of the following is the most likely diagnosis? Again, this is a clinical vignette that is talking about a patient with achalasia.